So good evening. I welcome all my students for this class, and I'm very, very enthralled always to take this, I call it a short session of just 1 hour in which I can teach you as much as possible, especially about those topics which are asked in your examination. And this 1 hour, I want to make it as productive as possible so that you people are able to not just write down in the exam, but also equally prepare for your Viva, because there are certain questions which can come at any point in time. See, infections in pregnancy is always and always a very, very fundamental topic. And like I say, for a person like me who's absolutely clear and concept wise and serology and otherwise about infections in pregnancy, I would just love to take you through different aspects in which I can catch you and take you to one infection or catch you for another infection and take your Viva there. So if you caught with a person like me in your examination, it will become a little difficult for you, which is why I want you to just pay attention in this 1 hour, and you'll be able to understand one topic is going to be clear in your mind forever. So today we're going to be dealing with hepatitis in pregnancy. I have brought for you those things which are important for your exams. Let's begin with a little bit of introduction about hepatitis. So this remains the leading cause of liver inflammation and liver cancer. It might even reach a stage of liver transplantation, because that is the morbidity of your liver disease in pregnancy especially. Viral hepatitis affects or can affect members of all populations worldwide, and we mostly see pregnant patients when they ask you whether we can have food outside or drinks outside. This is why your guarded answer will be to avoid it, because food, like we say, so many hepatitis, they are fecal-oral route, foodborne, and certain viruses which otherwise are not that lethal become very, very lethal during pregnancy, and will reach that place as well. So there are 6 identified viral hepatitis: A, B, C, D, and E, and the most recently described is the G virus. Hepatitis A virus and hepatitis E virus. Okay, they're important causes of maternal infections in endemic areas. India happens to be one for hepatitis E, especially, and even A. And HEV is associated with considerable morbidity and mortality. And since I was from Gangaram, Delhi, we were one of the most pioneers and really good institute for liver transplantation. So we got this burden of hepatitis E in pregnancy, a lot of patients to see. So the mortality in case of gynae and obstetrics was negligible, except for these kind of patients. So hepatitis E patients have seen a real morbid condition, and many of them could not be saved. So the baby survived, but the mother could not be saved. That has also happened. So it was a very, very gloomy, place to be in, because just imagine we're sitting at the most developed tertiary sector, known for liver transplantation. And what more do you want for a patient with, fulminant hepatic disease, I would say, rather than liver transplantation, and still we couldn't save the patient. So this is really, really morbid, really big mortality associated with hepatitis E, and a very disturbing case. Hepatitis D virus is an incomplete virus, and it's co-infected with hepatitis B. So usually when a patient is seen with hepatitis B virus, always go for a complete serology and complete diagnostic modality, including hepatitis D viral antigens. And that can cause a disease which is far more severe. In fact, can lead to fulminant hepatic necrosis. So that's the worst thing, because fulminant, that means acute and very, very dangerous, and proceeding and into bandwidth proportions in very less time. Hepatitis G virus, and RNA flavivirus, it's named as human Peggy virus or HPG virus. Why? Because it causes a parentally transmitted infection of the RE system, the reticuloendothelial system, like spleen and all as well. Okay, now a little bit of introduction or recapitulation, I should rather say. So you have most important thing in hepatitis is the jaundice, right? So when you're dealing with a patient which is showing frank jaundice, it's classified into pre-hepatic, hepatic, and post-hepatic. Okay, though I can go on and on only on the introduction as well. But since a lot of, we are not going to be dependent in hepatitis when we know it is hepatitis regarding this, conjugated or unconjugated. It's only for those conditions in which we do not know that jaundice is because of what. In that case, do you start having this kind of discussion that whether it is pre-hepatic or it is hepatic or it is post-hepatic. What you first get to see is just the serology report that the bilirubin is high. Now, if bilirubin is high, you always see the TBR and IBR, right? total, direct bilirubin or indirect bilirubin. So conjugated or unconjugated bilirubin. So if unconjugated bilirubin is high, that means either the liver is damaged or the liver stuck, it's not reaching. Whatever it is, it's not reaching the liver. So there is a problem before liver, or there is a problem in the liver because of which unconjugated bilirubin is high. Okay, and post-hepatic, that means if once the liver has done its work, okay, it has conjugated the bilirubin, in that case, post-hepatic jaundice you'll have more of conjugated bilirubin. That funda should be crystal clear. So when you're seeing the report and the bilirubin is high, the next question is always, what are you looking forward to in hepatitis? Is it the unconjugated bilirubin or the conjugated bilirubin? So obviously the liver is not functioning. How can it be conjugated then? It is always the unconjugated bilirubin which is high in pregnancy, in case of hepatitis. Okay, that funda should be clear, number one. Number two, you should all know these values. Okay, total bilirubin over here is in micromoles per liter, but it's almost the same, like, you just have to put a decimal over here, things will be, that it should be less than 1 or till 1, that's it, not more than that at all. Conjugated bilirubin and this unconjugated bilirubin, even if you do not remember the exact values, it's fine. But then comes ALT and APT, which is SGOT and PT. Now sometimes I've seen students fumbling on what ALT is SGOT or ALT is SGPT. Okay, so that also is the other important thing, which I had put a slide on that. I cannot see it right now. Anyways, so ALT and AST is also there. Alanine aminotransferase, that value is very, very important. So it should be less than 45, both of them. Just remember, both of them should be less than 45 international units per liter. In case of hepatitis, pregnancies like that, it goes above 1000. So anything which is less, let's say, around 100 is also fine. 200 is also fine. You can still think of your IHCP. But if a thing is touching 1000 or something like that, please, even 600 and above, please be hepatitis minded or something more catastrophic than that. We can't sit over it, right? Alkaline phosphatase increases in pregnancy. Gamma glutamyl transferase also increases in pregnancy, but not to those proportions as does increase in hepatitis. So with this background in mind, guys, let's start with the first hepatitis, which is